Hello. Well, in selecting this topic, we thought to ourselves, especially for the children and the adolescents, we most of the time can possibly, for example, understand the problem, but we cannot name it. We cannot properly diagnose it. So, just especially for the preschool children, and it's not a lot in our daily practice, but DC-05, that is what I'll be speaking about. That is the outline of my presentation. First, as a part of the topic, period-specific difficulties. What are they? You can see on the left side, 0 to 6 years of age. It's actually quite a short period of time, but so many radical changes and some developmental leaps occurring. These are the very first years of life, and it actually presents some difficulties in terms of psychopathologies, in understanding what is normal and what is abnormal. And there are some age-appropriate behaviors, and there are expectations about them, but they're based on various developmental theories or general accepted milestones in physical development. Both observation and assessment techniques are used, but it is mostly emotional, motor, sensory, language, cognitive, interactive, parent, and family functions were described in 1992, so it's mostly focusing on a comprehensive approach. As the fundamental health field, it has turned its focus to the presentation, course, and treatment of clinically significant mental health disorders. And therefore, it is very important to assess mental health symptoms and disorders in early childhood. So this is quite a reliable and a valid criteria, and there was a need for this. It actually has a multifactorial nature, and both environmental organic factors, neurological and physical functioning, the variable rate at which development occurs, but more importantly, the parent-infant relationship, which brings the topic to a different level. Another difficulty of this period is the absence or limited verbal communication, and the clinician communicates indirectly with the patient. That's the reason why we have to carefully observe the patient's behavior. And there is lack of a common language for diagnosis. Even if we have diagnostic criteria, still it's very difficult to apply them in children. Of course, looking at the psychiatric disorders, it's important to have a period-specific category. According to the studies, during this period, there is a disordered behavior which exists on a continuum and continues in the upcoming years. And there is a heterogeneity, and that's the reason why categorical model or nosology is relying on a categorical model ignores the evidence about heterogeneity, saying that neither dimensional nor categorical. Is it a symptom or a developmental difference? In clinical practice, it is DSM and ICD that we are mostly using, but there are different nosologies, DEC-05, which is the last revision. Depending on developmental differences, it is accommodated, and therefore it also helps us to understand the symptom manifestation and define disorders specific to early childhood. This is a preschool assessment tool that we have already prepared. As you can see, there's so many different tools that we can use, and for scales and all. For the age 0 to 6, there are so many items that must be assessed. So starting by 0, depending on the parents' also approach, we can possibly use it. It's very useful. Let's have a look at the history. As you all know, the ICD, how it is developed. It is 1850-90s, mostly lists of the reason for that. But of course, the main goal in here is listing the diseases and to record them, to register them, especially for statistical purposes. But it's after World War II. As you all know, after World War II, in particular in the United States, the Army, the veteran societies, in terms of putting a quick diagnosis for the outpatient clinics, it is ICD-6, that's including the psychological disorder, and it's also matching to DSM. In the course of time, it's also revised, more detailed diagnostic approach, multi-axial approaches introduced. And it is the SM4, which I'll be speaking about for all five, for infants and to 6 years of age. There's also the Turkish translation of this, you can see. For DSM, again, from the recent history, in DSM-4, it was actually infancy, childhood, and adolescence. There's such a category, and everything was under this. And in DSM-5 this time, it's actually a separate category, everything included in DSM-4 and 5. So I can say the infant or child category is there. If you, for example, write down the keywords infancy and childhood, this is also included in some of the other chapters, but there's actually no specific dedicated chapter for childhood. It's a very short period of time and so many radical changes. This is the history starting with 1994, 2016, the last revision. What is the change in here for infants and children, in particular developmental difficulties for very young children? So it is development-based category. So it's a multi-axial system, as I told you. The first, clinical disorders; the second, relational context; third, psychological health, and so. For DSM or ICD, why there was actually the need for an update, for a revision? Last year, for example, DC-03 revision after 10 years, because so many things in the literature, and therefore in 2013 DSM-5 published, and especially for very young age group to better capture the range of disorders for the infancy and early childhood. There was actually the need for a revision. DSM-5 actually, even if it is developmentally sensitive, still cannot meet the demand. Too many different meetings as a result of 3 years, it's all revised, so many different congresses, it is discussed, new diagnosis, and then always feedback, so it took some time to shape the revisions. In DC-05, the major thing is age, from 3 to 5. There is a diagnostic algorithm for each disorder. There is age limitation, duration criteria, distress and or functional impairment used as a criterion, and extends criteria to younger ages. And the most important thing is that it links to the corresponding DSM-5 to ICD-10 disorders. There's a link. There are some new disorders included, which I will mention. And for the third axis, both relation and secondly caregiving, yani the relationship with the caregiver in particular included. These are some of the global changes, new disorders and revised axis. For example, feeding behavior disorders, it is renamed. There are some new codes, certain numerical codes for these as well. In 3, for example, also physical diseases included. In the fourth axis, psychosocial stressors. And 5, developmental competency integrates different domains. Better help, like the emotional, social, relational. The goal in here is to recognize mental health and developmental challenges in infants and young children through 5 years old, and characterize the relationships and psychosocial stressors that contribute to mental health, and at the same time to have a systematic approach for the guide, and therefore providing a framework for formulation and intervention, and to encourage studies. And the new disorders, which I will mention in detail later. In Axis 1, in DSM-5, as we know, there are different Again, diagnostic groups: neurodevelopmental, sensory disorders, processing anxiety, mood disorders, obsessive compulsive, sleeping, trauma, and relationship disorders. Just as an example, and I just will go through in neurodevelopmental disorders, things that are very similar that we know, things that we're familiar with. And in the book, as a textbook, there's an introduction, diagnostic algorithm, diagnostic features, features supporting diagnosis, developmental features, prevalence, course, risk and prognostic features, culture-related, gender-related, differential diagnosis, and the link to DSM-5 and ICD-10. Again, the first for the diagnosis, there is, for example, there is the social communication symptoms. In B, in particular, anything cannot be explained by sensory impairment. In 3, repetitive behaviors. For age, no strict limit for this, but be careful, act with caution for less than 18 months old. Of course, it's possible to put a duration, but there is actually no specific duration for the symptoms. Only in this one I will speak in detail. There is mostly functional disorder. For example, the symptoms of the disorder, and in particular, the compliance of the parent. Does that, for example, create any trouble for the child? And especially, also what is actually the everyday routine of the family's participation, and of course the child, whether it limits the child's ability to learn and develop new skills. There are specifications like with or without global developmental delay, with language delay, genetic conditions and environmental factor, or anything associated with sensory processing abnormalities. Again, there is a link to DSM. Here as a new diagnosis, early atypical autism spectrum disorder. Also, it's a gray line for us in the clinics, at least for those having a social disorders and children between 9 and 36 months old, it's possible to put the diagnosis. Again, in here, there is actually a social communication criteria and repetitive and restrictive behavior, but it is not a must criteria. And in particular, we have to have a clear approach so as to avoid any future life issues. Another disorder, we, for example, cannot put a name for this. For the toddlers, overactivity disorder of the toddlerhood. Again, hyperactivity, pervasive, persistent, extreme. And developmental inappropriate hyperactivity and impulsivity is also expected for developing young children. But of course, it is like the predictor of hyperactivity at all times. It's not a hyperactivity as a syndrome alone, but this hyperactivity results in exclusion of the child from the others and also some safety issues. Again, you can see the diagnostic algorithm. Again, for those over 2, under 3. For example, it says the symptoms must be present for at least 6 months, and there is also a link. Another diagnostic group, sensory over-responsivity disorder. Sensory processing disorders are diagnosed, and especially there must be an abnormality in regulating sensory input. And some infants experience clinical significant and impairing responses to sensory stimuli. For example, it could be in the form of having an overreactive or the response latency being faster, or having, for example, could be right on the contrary, or atypically, for example, licking walls or door knobs. I mean, it can have different sensory again requirements, but for at least the pattern of sensory over-responsivity, it must be at least for 3 months. Here, over-responsivity disorder, and it actually has all the senses. You can see tactile, auditory, proprioceptive, interoceptive. As you all know, during anamnesis, we all can understand it but cannot name it. For sensory, for example, a normal level of decibel. For example, the blender, toilet or vacuum, for the auditory. For example, bright lights, moving color, or some spicy food, or pushes too hard without malice. I mean, there's something to do with proprioception. Or frequent, for example, erases through paper, or frequent stomach aches. It could be sensory processing disorder. It cannot be explained with autism. I mean, it should not meet autism criteria. But it's actually a more isolated diagnosis. Another group, anxiety disorders. In here, again, one of the difficulties, whether it's a phase of the normal development or something to do with future mood or anxiety disorders. You have to make a differentiation with the traits. Of course, for this age group, there is limited verbalization, so it's very difficult to put the diagnosis. So you have to very well observe the level of difficulty and anxiety, and especially parent observation is important. For those over 3 years old, can better verbalize, so they can represent internal experiences within their play. The symptoms and the content can be the same, but the picture could be different. And it must be, in particular, must be distinguished from developmentally typical anxiety and fears. For example, should occur 2 or more everyday activities, be uncontrollable and affecting the function with the family. Again, among the new diagnosis, inhibition to novelty disorder. As you all know, for slow to warm up and behaviorally inhibited temperaments, in contrast to them, it's a normal variant of individual dispositions, but it's mostly children sent to the primary care. It could be generalized anxiety disorder or social anxiety disorder. It could be a risk. It's especially for new situations, toys, activities, and persons, there is actually an inhibition and must be at least at the age of 2, and the symptoms should persist for more than 1 month. Again, we have the link as well. Another main group, mood disorders. Especially for early infancy, regulation of emotions is a difficult process, and there's a dyadic process. Especially in managing negative feeling states, the caregivers play a primary role. As you all know, the negative emotions are more closely linked to psychopathology than positive emotions. It is depression and irritability, the high-risk group. Once it is extreme, difficult to regulate, and if it is extended, then it can be a risk for mood disorder. Depressive disorder, for children in less than 24 months old, you have to put the diagnosis with caution. It means after 2 years, much better to put the diagnosis. Another new diagnosis, disorder of dysregulated anger and aggression of early childhood. This is a subset of children, and again, very difficult to regulate emotions and behaviors, and mostly impairment, stigma, and exclusion from age-appropriate activities. There's temper tantrums at the age of 2, and for example, there could be a limitation in prosocial activities, behaviors, whether pattern present for at least 3 months, lack of observable remorse or guilt, lack of observable empathy for others, and as an aggression type, proactive, reactive, or combined. And it says that it is actually a mood disorder. So, would you please wrap up? We have 3 minutes left. Obsessive compulsive disorder. The symptoms are similar, but the presentation could be different. And there could be some different ritualistic behaviors and preoccupations. It must be distinguished from impairing obsessions and compulsions. And there's again Tourette's disorder up to 18 months old. For sleep onset disorder, sleep eating and crying disorder, in eating disorder, overeating, undereating. For those in overeating, it's also an unrecognized one. They're always speaking about food. Even in between meals, they would like to eat something, and they stuff food in the cheeks when eating. If it is too much, again, if the percentile is high, you have to mention it. Also, under eating, very similar. Atypical eating disorder, also hoarding, and pica, rumination. Another one, crying disorder. Crying is an innate vocal signal of distress. And even if the basic needs of the infant is covered, still there's crying, like crying for more than 3 hours a day, 3 or more days a week for at least 3 weeks. And it's actually a self-limiting disease. Again, another trauma category. Trauma, stress and deprivation disorders, and put at the age of 12 months old. This is 9 months old. Especially, it's important to wait for attachment, and you have to pay attention whether witnessing that or so. And under the age, again, 12 months, more caution. Relationship disorder, as we all know, the symptom is always specific to the individual. And sometimes the symptoms can be similar, but the difference in here is that in relationship disorders, it could be characteristics of specific caregivers. For example, maybe for the teacher, but not for the other caregivers. So it's stable on its own, but still it actually can be different for each individual. Aggression, fearfulness, oppositional behavior, self-indulgent behavior, and the second axis, relational context. As I told you, it's important to assess the relation, but of course the environment where the relationship is, whether it's actually a powerful one, or you can see we have different scores in here, whether there is actually a social factor, dimensions of caregiving, and of course about the child's contribution to the relationship. If the relationship can be good, but if there is actually a temperament, disposition, sensory profile, physical appearance, physical health, mental health, and learning style may have different contributions from level 1 to level 4, 2, 3, high risk, and in 3 and 4 is high risk, so you have to intervene. This is the third one, dimensions of the caregiving environment. And in the third one, physical health conditions and considerations. In the axis 4, psychosocial and environmental assessor checklist. Now, like the primary support group, economic or criminal, it could be minority and other issues. They axis 5, the recent one, competency domain rating summary table. It is mostly whether exceeding developmental expectations, whether there's any inconsistency. And what is good about this book is that month by month, up to 12, up to 15 months old, there's a guidance saying for emotional, social, relational, language, social communication, what the children should do. So in conclusion, in the infant and the early childhood and adolescent, the investment in such mental health is extremely, the return on investment is so high. Early intervention is important, and therefore preventive and therapeutic interventions can be again useful for these patients. Thank you.